to our first Australian conference, Catherine. I'm so happy that you're here with us, and I'm looking forward to you sharing your knowledge with us on, you know, the psychosocial interventions of those living with sickle cell disease. So go away, go right ahead, not go away.
Thanks, Isabella. I'll share my screen and hopefully everybody's able to see that. Yep. Okay, so welcome to the subsession on support for people impacted by sickle cell disease. I'll refer to this condition as SCD, just for abbreviation and ease of speaking in the rest of my talk, which will focus, like Isabella said, on the options for community and psychosocial interventions for those individuals living with SCD. So I'm a consultant psychiatrist, and I work at the interface between medical illnesses, usually chronic medical illnesses, and mental health conditions. So this topic is very near to my heart. Because I'm privileged to be living and working in Melbourne on Wurundjeri land, I'd like to acknowledge the traditional owners of the land on which we're meeting. And I wish to pay my respects to their elders past and present, and to the Aboriginal elders of other communities who may be joining us here today. So as we've heard throughout this conference, SCD is a global health problem, and it has far-reaching psychosocial implications. We've just heard in the previous subsession about the Nigerian prevalences, and it was quite shocking to hear that about 150,000 births in the Aminu Kano Teaching Hospital in Nigeria result in children being born with sickle cell disease. So there's clearly an overrepresentation in people of color, and specifically within the Black African population. There's a reasonably high prevalence of about 0.001% to 0.002%. Just to put that into perspective, because some people might think, oh, that's not that high. In fact, it's 1 in 365 African Americans. So it's important to think about these individuals because they, as we've heard, have great impacts on education, employment, and their general quality of life, particularly as it relates to chronic pain. So we don't know the incidence in African and Afro-Caribbean populations yet, but it appears that this study that we were hearing about from Nigeria may shed some light on the impacts and the scope of the problem. So if we think about people who are living with sickle cell disease, they may experience, as I've said, chronic pain and fatigue, which then can result in many lost school days and loss of tertiary study opportunities and attendance. And that can then disadvantage them in terms of leading to a delay in attaining their academic qualifications. There may be also a loss of productivity in the workplace, with risks to their employment prospects and delays to their career progressions. So it's a serious disease. It's one that's worth noting, and it's definitely one that's worth thinking about how we can intervene early and what type of interventions will be most effective in trying to prevent these great impacts. It can take, on average, approximately 5 to 10 years for a person with a chronic illness, such as SCD, to attain the same level of study or career progression as someone without such an illness. As one can imagine, demoralization and loss of hope may be barriers to these SCD warriors in these particular aspects of life. If we then consider the psychological problems that can be most frequently encountered in chronic illnesses, much like SCD, we come to anxiety and depression, which are the most prevalent in up to just under 50% of this cohort. So a significant proportion of our society will be affected by anxiety and depression due to the burden of their chronic illness, specifically SCD. These patients often experience social isolation and withdrawal, as well as hostility, ostracization in some cultures, as we've heard in Nigeria, psychotic symptoms in certain cases, and low self-esteem. They may be faced with neurocognitive deficits, including things like learning difficulties, which may impede academic achievement, as already mentioned. They may exhibit internalizing behaviors, and by this I mean episodes of deliberate self-harm and introversion. They may also exhibit externalizing behaviors, where they may have recurrent anger outbursts and other forms of violence, such as property damage. Now, for those who attended some of yesterday's sessions, we were really privileged to hear from Dr. Marjorie Dejoie-Brewer, and she spoke about how people living with SCD can be exposed to disruptive interpersonal relationships and maladaptive patterns of coping. This can then lead to personality vulnerabilities and repeated mental health crises. If you throw COVID into the mix, these are people who've had a double stigmatizing illness in terms of vulnerability to COVID and the SCD itself. And we've already heard about how difficult it is for them to access care, to even just access screening and assessment. So societal expectations that are often unrealistic, coupled with stigmatizing attitudes and prejudiced beliefs that SCD is a disease of those who are cursed, can be further traumatizing. And this is seen predominantly in African populations, who may often believe that SCD and other chronic illnesses are due to having been in a certain family or be cursed in a certain way. So it's important that we raise awareness so that there's screening, but also a better understanding of the condition. So the key to good mental health lies in prevention and early intervention, if we're lucky enough. If we think of the screening first, so routine and regular screening for mental health symptoms, predominantly anxiety and depression in people with SCD, can help us identify these symptoms really early. And the advantage of doing that is, as I've already spoken about, you're able to intervene early and thus preserve any functioning that may be lost with delayed onset of treatment. I myself prefer to use the Beck Anxiety Inventory and the Beck Depression Inventory because they're easy. They're self-report screening tools, so the patients themselves are able to answer these questionnaires, and they've been translated into a number of other languages outside of English. So they're easily accessible to people of color and non-English speaking backgrounds. It's very helpful for this purpose to be able to identify these symptoms and then to advise about maintaining healthy lifestyles. This can include looking at nutrition. So again, we heard from Dr. Dejoie-Brewer yesterday that a diet that consists of mostly vegan or Mediterranean options, whole foods and plant-based foods, if you can, gluten-free, and limiting sugar, limiting caffeine. All these options are really healthy and promoting good mental health in addition to good physical health. Then we think about exercise, and we looked at how yoga can influence a person's mental health in addition to their physical health. And that can be done even with people with SCD who often have chronic pain and fatigue difficulties. Aerobic work, swimming, and remedial massage are other forms of gentle exercise that are often more acceptable to people with SCD and more accessible in terms of cost and availability. Sleep, it's very important to have highly restorative processes in order to have a good sleep-wake cycle, which then allows for adequate rest and recovery. The body needs this to eliminate any free radicals that have collected within the day, and these free radicals can lead to further illness. And then lastly, thinking about supplementation. So not just vitamins, but omega-3s as well and other minerals are really important. Engaging other practitioners, as we've just heard, the Nigerian cohort spoke about how they've engaged religious leaders in their study around newborn screening. A lot of cultures are highly influenced by their traditional healers and religious leaders, and it's important to get their buy-in to assist people living with SCD who consider religion and traditional cultures as pivotal to their lives. Vaccinations in this day and age of COVID-19, it's really important to have these advocacy discussions with our patients to protect them from illnesses that are otherwise preventable. Other vaccinations that are important to consider are the influenza vaccine and then all the routine childhood vaccinations as per the country's schedules, particularly tuberculosis. Limiting alcohol and caffeine for obvious reasons will help eradicate the free radicals, but also improve the pain tolerance and the fatigue levels of the individual living with SCD. And then lastly, avoiding smoking, which increases the free radicals in the human body, and definitely avoiding the use of illicit substances because these patients are already prone to psychotic symptoms as already been described. So then what can we do if we've bypassed the preventative measures and we've arrived at the diagnosis? We can then look at interventions, which can be secondary, so at a district level, and tertiary at a more macro level. So on a local level, self-management is really important. So looking at a comprehensive care model that is patient-focused and individualized for the person living with SCD is really important in terms of providing community and psychosocial interventions. For self-management, as we heard yesterday, self-awareness is a really important skill that needs to be developed. And this can be done using meditation, self-hypnosis, and reading self-help educational material. We can also incorporate exercise, as we've spoken about yoga and other forms of exercise, into the self-management program, and this can help manage the pain. Funding from programs like in Australia, the National Disability Insurance Scheme, but really from any insurance providers, could be put towards respite, preventative therapies, and early assessments of need, which can be pricey and out of the reach of most people living with SCD. Increasing awareness and increasing support from peers, as well as family and carer advocates, is really vital in supporting the person with SCD to tackle these symptoms and overcome any future burdens. It's very important then to also consider how we can move from self-management to disease management if the process has progressed. And in Australia, we have what are called chronic health plans, and these are funded by the government and allow the person with SCD to access mostly allied health colleagues like dietitians, exercise physiologists, but also certain types of medications that may not necessarily be covered for the indication of SCD, such as pain relief and antidepressant medications. Thinking about specialist care is really important for people with SCD because, as we've already mentioned, more aggressive and assertive treatment is key in maintaining functioning and improving their recovery from this condition and allowing them to experience as good a quality of life as possible. So this has two main arms: pharmacological, which is medications. So what's available out there for people with SCD are anti-anxiety and antidepressant medications, as well as pain relief in terms of opiate analgesics and others. This is always done in conjunction with psychiatrists and pain physicians. The second arm of specialist care is psychological. The two main therapies that have some evidence in the treatment of anxiety and depression in SCD are cognitive behavior therapy, which is CBT, and assertive and acceptance commitment therapy, so ACT. These two types of therapy look at the mindset of the person with a chronic illness and then use those thoughts to modify their behavior, and in that way to modify their pain experience and other symptoms that they're experiencing. Lastly, thinking about complementary and alternative medicine, we can think about less evidence-based but still highly effective treatments such as biofeedback and acupuncture. There's also music therapy, art therapy, remedial massage, and equine therapy. And this is where the funding from insurance companies can come in really handy in terms of being able to fund these complementary and alternative medical therapies, but also in terms of accessing them where they might otherwise not be available. And lastly, thinking about monitoring and research. So looking into the future and thinking about the next steps for people living with SCD, we've already identified that a lot of the studies have been done in the Western or more developed populations, such as in the USA and some in Europe, and mostly have focused on African American populations. But it's really heartening and encouraging to hear how Nigeria and other African countries have been looking into funding screening programs and other sorts of studies so that we can understand the scope of the problem and also understand what specific therapies will be beneficial for people in African and Afro-Caribbean populations. So further research is certainly required in those nations, and specifically thinking about what kind of questionnaires can be used to assess their mood and anxiety levels, specifically for SCD. A lot of the populations have been either children under 12 or adults. So looking at adolescent cohorts is really important. Lastly, thinking about the best practice psychological and pharmacological treatments is really important. We need more randomized controlled trials in African populations to focus on what kind of psychosocial interventions would be beneficial for people with SCD and why, if they're different to the ones already known to be beneficial in westernized or developed countries. I have a list of my references available for anybody who's interested, and I'm happy to take questions.
Thank you, Catherine. That was a great presentation. There are a few questions in our chat box if you are willing to answer those. I can go through for you if you would like. Would you mind
stop sharing?
Yeah.
That's it.
Okay, yeah, that'd be
yes.
great. So I've got here one of the first questions, which is from, it's popping up from David. My question is about the psychosocial effects of chronic fatigue syndrome and chronic pain syndrome in sickle cell warriors. Both conditions affect your mood, sleep, and relationship with people. Because both seems to drain your strength, especially chronic fatigue. Just let me scroll it up. You intentionally withdraw from relationships or people who argue or tends to argue more in discussions simply because you seem not to have the strength to engage in arguments. This unfortunately affects your relationship with these people, even your loved ones. How do you manage these?
Yeah, that's a really important question from David. And it's one that I grapple with every single day because chronic fatigue syndrome and chronic pain are really complex conditions to manage on their own. And then if you factor in the SCD, there's just that added layer of complexity. So good assessment, which includes a comprehensive history and a good mental state examination, are the first place to start so that you can get an idea of which are the most distressing symptoms and which will be most appropriately treated by which modalities. I usually start with psychotherapy, and a lot of these symptoms that David has described here are quite responsive to firstly supportive therapy, but then once the person's better able to engage with the cognitive behavior therapy that I mentioned before. But it is a complex situation to address.
Absolutely. He also asks, how do you self-hypnotize?
Yeah, that's a good question as well.
Yes,
And so generally self-hypnosis begins with having attended regular hypnosis with a trained hypnotherapist, and then they will provide you with the skills to hypnotize yourself. It's more like very deep meditation rather than completely losing consciousness. So the term is a bit of a misnomer, but it has been shown to be beneficial for a certain cohort of people who've tried various other treatments. It's not a commonly used treatment.
I also had a question myself, and that was how successful is cognitive behavioral therapies and ACT with sickle cell warriors. How successful is that?
When it's implemented early, it's really successful. So we often get young people. So I've seen about 2, middle teenagers, so 14, 15-year-olds. And once we catch them at that stage, this is why I was emphasizing early intervention, then it's quite helpful. Often by the time people's symptoms are entrenched, then cognitive behavior therapy is more to just manage living with those symptoms rather than completely eradicating the anxiety and depression in itself.
There's another comment from David in the chat there where he says some of the psychological symptoms I experience with both conditions are, and he hasn't mentioned any further than that. I can't see any further than that in there. There we go.
Typing.
He still is. Irritability, tiredness, hopelessness, low or no interest in things that normally interest you. How can we help, David?
Yeah, those sound like depressive symptoms, David. Just that anhedonia, which is the loss of interest in things that you previously enjoyed, the irritability, the tiredness, the hopelessness. So those need to be really well assessed by a psychiatrist or psychologist. And then the severity of those symptoms needs to be determined, because that sounds quite concerning, given that there are quite a number of symptoms. And then antidepressant medication needs to be considered in combination with the therapies we've already discussed.
How do you know, Catherine, when people that have these particular symptoms know when the right time to reach out is to get help?
That's another good question. I think it's whenever you recognize that there's a problem is the right time to reach out. Sometimes I get patients say, oh, I waited until I was really bad to come and see you. And I wish that people didn't do that, because like I said, the earlier we can get to treat these symptoms, the better the recovery and the more we can preserve the function. So as soon as you recognize a change in your mood or in your functioning, that's the time to seek help.
David has added to his chat once again. He said, I've seen a psychiatrist and he has placed me on antidepressants. But sometimes I still have those symptoms.
Yeah.
And I guess that wouldn't they be like the side effects sometimes of the antidepressants as well?
They can be side effects. They can be a whole different condition. So we've heard with SCD, you can get other conditions within that. And anemia is a big one. So it's important to double check that you don't have something else going on. But also just important to recognize that antidepressants won't necessarily eradicate all your symptoms, and you may find that you need to live with some symptoms.
Okay. We have a question from Donna McCurry. Thoughts on screening and treating for vitamin D deficiency, given low levels might contribute to mood problems and fatigue? What do you?
Yeah, absolutely. I would say, Donna, you definitely need to screen. At least once a year, I get my patients to do vitamin D blood test. It's a simple blood test, not expensive, and also easy to treat if you do find that it's low. The supplements aren't too expensive, but it makes a big difference to people's mood and energy levels if you do treat.
Okay, that's interesting. I haven't heard that before. That low vitamin D levels may cause those symptoms also.
Absolutely.
Okay, yeah. David is back again.
And Natalie.
Yeah. Yes, Natalie's also posting from our Hoover app. So I believe, is that right, Natalie?
No, I've actually just typed in the chat.
Okay. Good job.
Yeah.
How
But
can,
yeah.
yeah, that's a good one. Do you want to
How
ask
can
it? Maybe?
stigma be tackled?
Yeah,
Yeah.
yeah. You know, and the reason I'm also asking it is earlier on we had a question about, you know, how someone would feel if their doctor or GP sent them to a psychiatrist. I think the sense that I got, and I hope I'm wrong, was that probably depending also on where we are in the world, sometimes, you know, having to go to a psychiatrist is looked at as if you might be off the rails,
Yes.
colloquially, yes. And yeah, then it might actually prevent some people from seeking the help that they might need. So I think maybe if we have an understanding of what a clinical psychologist is and what a psychiatrist is, I would really appreciate that. Thank you, Dr. Catherine.
Yeah, absolutely. So a clinical psychologist is not a medical doctor. They've trained in therapy. So they've often got a degree in psychology and may have further degrees in the area. And they mostly focus on talk therapy. A number of them do make diagnoses. Generally, they focus on the therapy. Psychiatrist is a medical doctor who studied for, you know, their undergraduate basic degree, 6 years or so, and then has done further training of approximately 4 to 5 years to become a specialist medical practitioner, in other words, a psychiatrist. And we make diagnoses, we make treatment recommendations, we can do talk therapy as well. We can do other treatments like electroconvulsive therapy, which is ECT, and a number of other treatments. The stigma question is a big one, and it starts with awareness. So raising awareness is the only way to eradicate stigma of any kind. Normalizing, you know, talk about mental health, which in Australia, fortunately, is happening, but I appreciate it does depend on where you are in the rest of the world. And our African countries are not quite as advanced in that area as the Western world is in terms of accepting mental health difficulties and talking about them openly.
Okay. I know David's also added another
I think
comment.
Agnes
Thank
has
you,
her hand
David,
up.
for all of your comments. They're just fantastic.
I do. Sorry. I just, because I know we have these like double sessions. I just want to quickly say thank you so much, Catherine. I've heard you speak before, and I just said, you know, when we are talking about the theme of this conference was us breaking the barriers with the mental health aspect to, you know, breaking the barriers as in talking about what we are experiencing, and we thought there's no better person to invite than yourself. We've heard you speak before, and just wanted to thank you for supporting our organization and the work you do in terms of mental health. We will reach out because we are in the process of trying to work on a tool or something, a mental health support for our organization. We've started the process already, and we hopefully this year or later next year, with the COVID, everything has sort of put on you know, but we'll reach out and just see how you can help us plan this tool we are trying to implement in our organization. But thank you so much for all you do and for supporting our organization. So I'll just go and support our volunteers now. Yeah. No,
Thanks, Agnes.
Thank you so much. It was lovely to see you.
You too.
Oh, better unmute myself. Okay, I'm just mindful of the time. We've got another session happening about 6 minutes ago.
Yes, yes. I'm happy to answer any questions by email if anyone's wanting to send some, including David, because I see we haven't answered his.
Yes, okay. We can always have a look at that one if you'd like. It's basically a statement in there. So if you would like to have a look through that.
Yeah, so with chronic fatigue syndrome, you feel confused because you don't know what's wrong with you, you feel weaker, dizzier after resting than before resting. I think getting someone to discuss and voice out your experiences brings some relief. It helped me with chronic fatigue syndrome. Absolutely. When I discussed with the hematopathologist about CFS, she shared a lot of information with me, which was quite relieving. Well, this is encouraging, David. And she made me know she has treated many sickle cell warriors experiencing CFS. It commonly occurs at age 35 or 40 and upwards, the use of some medications, and she emphasized getting a sleep therapist because you cannot manage the sleep disorders yourself. I agree with all of that. Absolutely.
Well, I'd like to say thank you very much, Catherine, for coming on board and sharing this. It's such an important topic. It really is, especially with people suffering from severe chronic conditions, and sickle cell being one of them. So, and it's actually good to see that over the years where it was not even looked at, mental health, and now all of a sudden it's right there in the picture. And I think that is part of healing, you know. It's not just about being treated with medicines or, you know, it's also about diet, it's also about mental health. All those things work together in making sure that we all live a, you know, a somewhat normal life.
Absolutely.
All the help that we can get. So thank you very much for sharing everything that you did. I'd like to also thank my panelist friends that are with me, Natalie and Shane. I don't know if you'd like to say some parting words, but we'll be moving very shortly over to the next session that's happening right at this time. Thank you very much.
Thank you.
Thanks, Catherine. Really appreciate it.
Thanks, Natalie.
Thank you, Doctor. That was awesome. Thank you.
Thanks, Shane.
See you next time. Bye.
Bye.